N-Contact Surgical introduces a breakthrough technology in endoscopic access and lesion creation for the treatment of atrial fibrillation. The technology consists of an innovative suction irrigated radiofrequency coil named Visitrax, deployed utilizing a cannula through the abdomen. The system can create any desired lesion without chest incisions or lung deflation. Through the abdomen, linear lesions are created epicardially, seen here in blue. Afterwards, an electrophysiologist maps the electrical activity of the heart and connects areas that were not accessible to the surgeon with an ablation catheter from the inside, shown in green. Access to the posterior of the heart is achieved through a small incision located in the midline of the abdomen. The cannula is inserted through the abdomen and into the pericardial space, exposing the junction between the inferior right pulmonary vein and the inferior vena cava, providing a reference point to identify landmarks on the heart. All cannula movements may be initiated from this readily identifiable landmark. In this example, a lesion is created from the coronary sinus along the posterior left pulmonary veins. The Visitrax device uses suction and irrigation to assure consistent tissue contact and complete lesions. When finished, it is retracted, exposing a visible lesion. The cannula and device may be manipulated along the posterior left atrium to extend the lesion towards the right pulmonary veins. Sequential lesions may be created by moving the cannula, Visitrax device, and guide wire. In this example, the device is extended along the posterior right pulmonary veins from the left atrial roof towards the coronary sinus, adjacent to the inferior vena cava. When creating lesions along the anterior right pulmonary veins, the cannula is lifted over the inferior vena cava until the right pulmonary veins and Watterson's groove are visible. Once finished with the anterior right lesions, the cannula can be rotated back over the inferior vena cava towards the left pulmonary veins. The cannula can be lifted over the left pulmonary veins to expose their anterior aspect, as well as the base of the left atrial appendage and the ligament of Marshall. The surgeon has direct visualization of the Visitrax device at all times, ensuring correct placement. After creating the desired epicardial lesions, the cannula is removed from the abdomen and the incisions are closed. At this point, catheters are inserted by the electrophysiologist into the atria, allowing detailed electrical mapping the heart and the creation of endocardial connecting lesions in areas not accessible surgically. Using electrical maps, the epicardial lesions seen in white are connected from inside the atrium using an ablation catheter until the electrophysiologist demonstrates absence of electrical activity and pulmonary vein isolation confirmed by exit and entrance block. This groundbreaking technology enables interdisciplinary collaboration amongst surgeons with their ability to create complete linear lesions epicardially without chest incisions or ports, and electrophysiologists who can utilize mapping, endocardial ablation, and diagnostic techniques to confirm procedure completeness. The convergent approach offers patients a comprehensive, closed-chest, minimally invasive treatment for atrial fibrillation.